to the Sigma induction. That is a clinical day, and you've got some options in my class as well. Anyway, I'm not speaking for anybody else. And somebody's got that recorded, so when you tell those other faculty I will say, get one of those recordings and find out what I really said. In my class, you can request to change that date if you're clinical, if you want to do that, or you can leave early from clinical to go to the induction. So it is a clinical date, and I recognize that. They'll think about that, and so that happens from time to time. So there's your options. You can either change the date to some other date if you want to. Just send me a message, and I'll delete out the date. You can select whichever one you've got, that's remaining out there. Or you can just leave early from the clinical so that you can be at the induction because it starts at 7. So everybody understand that part? What if you have a clinical in mother baby that day? You got to go talk to Leo. You cannot say Professor Lockhart said. Although if I know Dr. Jansen, she's going to let you change that. She's much sweeter than I am. So if I let you change it, you're probably pretty golden with her. Also, too, there's a rumor going around that Mary Anderson knows exactly what's on this test. That I told her what's on this test and I didn't tell any other faculty. Well, I'm hoping she tells me because I haven't done the test yet. So maybe she'll tell me what's going to be on this test. Actually, what happened with Professor Anderson was a couple of weeks ago, maybe somewhere in that time frame, she got the schedule with the calendar with those different units on it, and she asked me, when I say endocrine, what do I mean? And I told her which conditions in endocrine I thought were the most important for students to know. And then day for yesterday, the days all went together for me. But the last 2 days, she was in my office and talking about what she was going over with different students. And we had a conversation about I will not be pressured into limiting the disorders to whatever you think I should be limiting them to. And that this is not a med-surg class, this is a decision-making class. And so I'm not disclosing what disorders I'm testing over, and actually at this moment I don't know because it's not in the matter. It's not about the disorders. It is about the decisions based on those unit outcomes, and I referred her to those unit outcomes as well. Okay, so she doesn't know and everybody else is clueless because nobody knows at this point if I ever wrote the test yet. I have, with ExamSoft, I have all sorts of questions in there, tons and tons of questions. I just have to go in and select the ones I want. Okay, so we're going to do ventilated patients today, and here's our patient, a 25-year-old. She has hantavirus infection. She's suspected of contracted the infection while cleaning the house that had not been lived in for 3 years. She is experiencing pneumonia and is placed on mechanical ventilation. She's 5'4" tall and weighs 132 pounds. Oh, she and I, same size. We're the same height. Does that count?
That counts.
After insertion of a 7.0 oral endotracheal tube, the patient's placed on AC ventilation at a rate of 16 breaths per minute with a tidal volume of 350 milliliters and FiO2 of 0.50 and P of 5 centimeters of water. So these are her ventilator settings. These are her vital signs: 108/64, 118 pulse rate, 14 respirations, 100.6 degrees Fahrenheit temp. She is receiving enteral nutrition via a PEG tube. Her 3 children, aged 2, 4, and 6, are staying with her mother, and her husband has to work full-time to maintain their medical insurance. Well, at least we know she's got insurance. Anything there of concern to you at this point? She has limited support, doesn't she? Her husband's working, her mother's keeping the children, so who's visiting her, so to speak? Anything else of concern? Her heart rate's up. Yeah, her heart rate's up. Other than that, she's looking pretty good, isn't she? Describe the type of ventilation her ventilator is administering. I'll go back and show you. What does that mean, AC ventilation? Assist control, what does that mean? It's assisting her? What's that control mean? It's going to give her a certain rate. And what rate is it going to give her? 16 breaths per minute. It's going to give her 16 breaths per minute, isn't it? Do you know what this means? The amount of air that goes into the lungs. How about the IO2? 50% what? Yes, 50% what? Oxygen. Of the air they put in her lungs, 50% of it's oxygen. Very good. And what's PEEP? It's the pressure that's put where? Specific pressure. At the very end of expiration, to put a little pressure there. Why do you suppose they put that pressure there? Yeah, it's to keep that alveoli open. That's exactly right. Very good. A lot of times students don't know any of this. So that's very good that some of you do. Some of you are paying attention when you're in the ICU as to what those ventilator settings are. How would you know if this patient's experiencing any pain or anxiety? She's got an endotracheal tube in place. How would you know if she's experiencing any pain or anxiety? What would happen with her vital signs? An increased heart rate. Her heart rate's already 118. Does that mean she's anxious? Anything else that would tell you? What will happen to the blood pressure? And her blood pressure is not high. Anything else? Remember, she's young. Y'all got to remember she's young. Her vital signs are not going to be great indicators of things like anxiety. Maybe your heart rate's the easiest thing to adjust. You know, almost anything will make a heart rate go up or down depending on the attack. And but she's young, so homeostasis is going to be strong. She's only 25. So blood pressure is not going to be your best measure. So what else is going to tell us pain or anxiety? Maybe she's diaphoretic, grimacing, fighting, restless, that type of stuff. That could be much better indicators. Also, frequent high pressure alarms. What does a high pressure alarm mean? It means obstruction, right? It means obstruction. The air's having to go against increased pressure to get in, so it's alarming. It's telling us, wait a minute, we shouldn't have to push so hard to get in. We can't get in. That air can't get in. And that comes sometimes from obstruction to the tube, but also from fighting the tube. She's putting some obstruction on it. Good, very, very good. What actions can you do to help reduce this patient's anxiety? If you had a tube down your throat, would you be anxious? Yes. So what kinds of things would you want done for you if you were awake with this tube? What kind of things would you want done for you to help reduce your anxiety? Well, people that talk to you, don't you? They don't tell every single thing that's happening and what's going to happen, right? You want to know exactly what's going on and what's going to happen in the future. You want that kind of reassurance. What else might be relaxing to you? some kind of stimulus like that, TV, maybe some music would be good. How about dim lights? Wouldn't that be nice and relaxing? Not to have the bright overhead lights on. Might be some really good stuff to do. How about determining a method for her to communicate? Wouldn't that be good? If she's awake with that tube, she can't talk, but that doesn't mean she can't write or use a communication board, right? So that'd be a good thing for her to do. Encouraging her to have some familiar belongings. She has small children, maybe some photographs or some of the work that they've done, you know, paintings or pictures or stuff that they've done. Maybe there's something, a favorite blanket that she likes at home, something that's comforting. When her husband's there, let's give him some privacy. Informing her what's going on in the rest of the world, so she doesn't get that whole isolated sense that it's just her and nobody else is around and nothing else is going on. So keeping her, you know, it's raining today, or you know, it's sunny, it's warm. I wouldn't just overwhelm her with all the bad news in the news, but I'd certainly give her some updates as to what's going on in our world. I'd probably, right now, if I'm taking care of her, talking about the Trump versus Clinton. Yeah, that'll be humorous. That's going to be a good one, isn't it? I swear the Democrats hired Trump to run for the Republicans. I swear to God. I just can't imagine that it could have happened any better for them. So it's as good as reality TV. And providing consistent care. So trying to get her the same nurse each day, that would help, wouldn't it? That would help. If she had the same nurse as much as possible, so she kind of builds a relationship with that nurse. And also timing activities to avoid fatigue. That is always an issue in the ICU. Time those activities so you're not overwhelming their energy level. The patient uses the communication board, tells you that she's anxious but not hurting. You have the following orders available. Which agent will you give and why? Ativan? Why? It's specific for anxiety. There's another reason. That's a good one, but there's one more. Not gonna, we don't have to worry about respiratory depression with her. She's on a ventilator. It's going to give her breath whether she's breathing or not. So respiratory depression is not a big issue here, is it? She's on a ventilator that's giving her respirations each time that she does it. So that's not a huge concern. This one's going to be less sedated. This one's going to put her out, you know? Boom, she's gone. She's going to be sleeping in la la land. This one not only can sedate her, it's for pain, and it causes more nausea and stuff than the other two do. So let's give her the lorazepam, just give her a little bit to decrease some anxiety. The physician order reads lorazepam 1 milligram IV 4 hours PRN. You have available the lorazepam 2 milligrams per milliliter. So how many milliliters will you administer? Half a mil, and how will you dilute it? Okay, you're going to use normal saline. How much? I'm sorry? Look in the drug book. You're going to look in the drug book and see how much? I don't see anybody looking in the drug books and seeing how much. 2 to 3 mils. It has to be in at least equal volume. So if you're giving a half a mil, you have to put in another half a mil. Lorazepam has to be in at least equal volume. You could put in more if you wanted to.
Is that specific?
The injectable benzos. Yeah, be ready to use it because it will crystallize. That's exactly right. Later in the shift, you note that this patient's cheeks billow outward each time the ventilator delivers a breath. You're also receiving a low pressure alarm from the ventilator. What is likely causing this? I'm sorry? It's dislodged. Yes, what you're trying to say. Yes, it's dislodged. Or the balloon has burst, or or deflated, there's a leak. That means the air is going in too easy. So you get a low pressure one, not enough pressure. So there's a dislodgement. You know that the endotracheal tube is dislodged. Which healthcare provider will you notify to replace the tube? The respiratory care therapist? Yes, respiratory care therapists are the most common in the healthcare agency to replace the tube, but it might be in this particular agency an anesthesiologist or even a hospitalist or even the primary care, which this slide prompts me to talk about. How do we know who to notify? How do we know? I'm sorry? There's usually not real policies on this. Certainly in this case, the respiratory care therapist is going to have to be by policy permission to do this because it's usually going to take a little drugs. So in that case, there's going to have to be some drug protocols for them to follow. So usually if the respiratory care therapist is the one doing the intubations, there are policies on that. But how do you know which doctor to call in any situation or which healthcare provider to call? When your patient's having a complication, how do you know who to call?
Depends on what the patient is having. She's having a respiratory problem, so we contact her.
If it is a respiratory problem, you would call the respiratory doc if one is on for that patient. As you've probably already ascertained, these patients have multiple providers, don't they? And so if the problem is respiratory and the patient has a pulmonologist, we'll call the pulmonologist. Good. What if the patient, in this case, she's got the ventilator and that sort of thing, but all of a sudden she develops abdominal pain and she doesn't have a gastroenterologist. Now who do we call? I'm sorry? The hospitalist, or if there is no hospitalist, what's the other one? Yeah, whoever's the admission provider, which is typically the primary provider if there is a primary provider. So if the condition is something they don't have already a specialist doing, and there's nobody there that kind of goes with that specialty, then you will do the admission, whoever admitted the patient. What about if you're in PACU and there's a problem? Who do they call? Anesthesia. I don't know what the problem is, they call anesthesia, right? That's really the only time we call anesthesia as the doctor. It's when it's a surgical problem in PACU. It's when we call the anesthesia. If it's a surgical problem, let's say that the patient had surgery and it's been 8 hours and there's no urinary output. The surgeon is not the admitting doctor, but the patient had surgery. Now we have low urinary output. Who are we going to call? The surgeon, because we think it's a surgery-related problem. That's how we make those decisions. That's how we make those decisions on who to call. If you have no idea, it's usually pretty safe to call the admitting doctor or the hospitalist. However, you can get into some cantankerousness about that. Well, why are you calling me? They have a pulmonologist and this is a pulmonology problem. So if they have a provider that works on that particular body system that's in trouble, call that person. If they've had surgery and they're in PACU, call the anesthesiologist. If they've had surgery and you think the problem is related to the surgery, you call the surgeon. That help you? Yeah, it's kind of, because you're not going to find this in a book anywhere. It's just the way it is. This patient needs to be suctioned. Describe the procedure for closed system suctioning. What do we do? Y'all know what closed system suctioning is? The device is already hooked to the endotracheal tube, which is more common than in open suctioning, isn't it? And that's the way the system stays closed all the way through. So the device is continuously connected to the endotracheal tube. So now when we suction, what do we have to do?
Hyperoxygenate.
I'm sorry? Always have to hyperoxygenate, good. Then, think about how it's different than open suction. You know? You use clean gloves because it has a sheath that's protecting the catheter, don't you? So you can just use clean gloves. It's got a sheath there. Most of everything else is about the same. The catheter will already be the half diameter, or hopefully they put that one on there. Suction between 80 and 120. Use the ventilator to hyperventilate the lungs. Open the access valve, advance the catheter. Use the suction valve, let suction for not more than 10 seconds as it's being withdrawn. Provide 100% oxygen. Clean the suction strip attaching it to saline unit dose vial to the irrigation port. And remove gloves, and I should say wash hands, not was hands. 2 days later, the physician elects to insert a number 8 Shiley tracheostomy tube with a disposable inner cannula. The patient becomes very anxious after hearing this news. Describe the teaching you will implement. The medications that will be given, you're going to reassure her that there will be medications so that she does not feel the insertion for this. There's something even more important than that, though.
Explain the procedure.
Now, what's most important, though?
Explain the procedure.
The procedure, what about the procedure? And almost everybody knows what a tracheostomy tube is. They've seen enough ER on TV and that sort of thing where they slit the throat and put these tubes in. Almost everybody knows. So that's what's scaring her, is she's thinking they're going to split her throat and put a tube in there. But what do you know that's going to make her feel better? It may not be permanent. Most likely won't be permanent. It's going to be better. Once they get that tube in there, she will be able to obstruct it and cough. That's the first thing I would highlight to her. Once they put this in, they're going to take the other one out. Your mouth will be free, and you will be able to cough. Imagine what a big motivator that will be for her. And like you say, it's not permanent. The cut's not deep. That's not deep. They're not slicing the throat. What makes slicing the throat is cutting arteries. They're not going to do that. They're just going to slice very shallowly in there to get to the windpipe so they can open it up. The medications will keep her from hurting. So beautiful. During the procedure, the physician elects to start a propofol drip at 5 micrograms per kilogram per minute. The patient weighs 60 kilograms. On hand, you have Diprovan 50 milliliters, 10 milligrams per 1 milliliter. What rate will you use this medication? One 1.5 watts. 1.5 mils per hour. Is that what everybody got? And what's the volume to be infused? 50 mils per hour. I've only got 1.8. The patient undergoes the tracheostomy procedure without complications. When you return the following morning and assess the new tracheostomy, you note that the trach tube looks tight. You are unable to insert one finger between the patient's neck and the trach tube. So you're unable to put a finger in there. What action will you take?
Loosen it.
I'm sorry?
Loosen it.
Loosen it?
Or which one?
You got, you're trying to put your finger between the tube and the patient's neck and you can't.
Oh.
What are you gonna do? Call the doctor, which doctor? The pulmonologist. We're gonna palpate for subcutaneous emphysema, we're gonna inspect for inflammation and ischemia, we're gonna notify the physician, and we're gonna expect in order to loosen the ties. That's what we expect. So the next question is, which doctor are you going to call? Are you gonna call the pulmonologist? The person who inserted it, that's right. Because it'll be a complication of that procedure. Good job. You know that clicking or slight popping sound in the tubing of her ventilator circuit, what action will you take? What action will you take? Suction? It's in the ventilator circuit. We're going to check the tubing, what are we going to do? And it has nothing to do with connection. There's condensation. So you're going to descend the tubing and allow the condensation to flow out of the tube. Condensation will collect. Have y'all seen that in ICU? Condensation will collect in that tube and make a little popping sound. So we need to let that flow out of there so it's not staying in there with allowing bacteria to grow. What position will best facilitate the client's respiratory efforts? What position? Semi-Fowlers? About 30 to 40. Did you know prone will too, but we don't use it a lot. The prone position works well too. Name the four principles of ventilator bundle care. Do you know what those are? Oral care is one. Check. We got three more. Oral care is one. Y'all been in ICU. When you're in ICU, are you taking care of patients on ventilators? How many of you have taken care of a patient on a ventilator in ICU? Okay. How come the rest of you that's gone to ICU hasn't taken care of a patient on a ventilator? Oh, there's lots of you been to ICU. Can we pull up the names and call y'all out? Don't lie to me. I type those things out all the time. A lot of you been to ICU. We're not paying attention. Elevation of the head of the bed. They need to have sedation vacations. This patient hasn't been sedated other than when they put the trach in, so she doesn't need a sedation vacation. Assessment of readiness to extubate, so that's one of our responsibilities. Peptic ulcer disease prophylaxis, what does that mean? Giving them proton pump inhibitors or H2 receptor inhibitors, one or the other. H2 receptor inhibitors are much less expensive, and they work almost as well. I don't know why we don't use them more often. Deep vein thrombosis prophylaxis, what does that mean? Yeah, Lovenox or some form of anticoagulant. Doesn't have to be Lovenox, but a lot of times it is. Change the circuit only when visibly dirty or has been contaminated. It's another one. I need to put 5. I actually need to put 6 because oral care is good too. This kind is prescribed as famotidine, 20 milligrams IV. The pharmacy sends Pepsid 20 milligrams 1 meal. Describe how you will prepare this medication for administration and the rate of infusion. You believe you can what? I believe you can't slam it in. I believe that would be wrong. Anybody know? Where are we going to find this information? Now, y'all are never looking in your drug book, so you know it. You're letting the nurse tell you, aren't you? And the nurse might have told you to slam this in. Must be diluted in 5 to 10 milliliters of saline and infused over 2 minutes. Must be diluted. Y'all know what type of drug this is? It's an H2 inhibitor. H2 receptor inhibitor, yes, it is. Later in the day, you know that the patient desaturates when turned to her right side. You auscultate tubular breath sounds in the entire right lung posteriorly. Explain the probable cause of this desaturation. Essentially, what causes tubular breath sounds? Do you know? This is what happens when students treat clinical as daycare and treat classroom information as test questions. You have been told what happens, yes, you're right. You've been told what happens with these breath sounds. You've gotten that information more than once. But you haven't applied it to a situation where there's been a patient that hasn't. But you're absolutely right, fluid consolidation. That's an indicator of consolidation in that lung. As that air goes through consolidation, it's going to enhance that sound, isn't it? Y'all heard of things like cacophony, whisper pectoriloquy. This patient is receiving Pulmicare at 75 mils per hour via K-tube. The Pulmicare delivers 1.5 calories per meal. It also delivers 0.0 grams of protein per meal. How many calories is this patient receiving per day? Twenty-seven hundred, and how many grams of protein? You should have known that's going to be this question.
108.
Okay. So she's receiving 2,700 calories a day, and she's receiving 108 grams of protein per day. Why do I care? She's got to have adequate protein and calories to heal, does she not?
Yes.
All right. She requires 4 calories per kilogram and 1.5 grams of protein per kilogram each day, and she weighs 60 kilograms. Is she receiving enough calories and protein? Let's see how many calories a day does she require.
Is it 40 calories?
40 times 60 is how much? 2,400, and she's receiving 2,700. So we're happy with that, aren't we? She requires 1.5 grams per kilogram. So how many grams of protein does she require?
90.
And how much is she receiving?
108.
So we're happy with that, aren't we? It's much easier to get sufficient. It's much easier to get sufficient with enteral feedings. With parenteral feedings, it's much, much harder. And the reason it's so much harder with parenteral is they have to make it so hypertonic to give enough fats, carbohydrates, and proteins that the patients oftentimes can't tolerate it. Because when it's very hypertonic, like with TPN, that's very hypertonic, what kinds of problems will occur? If you're getting TPN, it's very hypertonic to give enough calories and proteins. What types of problems will occur then? I'm sorry? Hyper what? Hyperglycemia is one. What else? The side effects of TPN. Fluid volume excess, you really got to balance that with dehydration, because it's so hypertonic, you have too much solutes for the amount of water. So it can go either way. It can certainly go either way with TPN. You got fluid and electrolyte shifts with TPN. With enteral feedings, what are the complications? The enteral feedings. Diarrhea and dehydration. Now, when you look at those, it's much easier, and plus the TPN has to go through a central line, right? We forgot about that one. Anything that's 10% or higher, higher than 10% dextrose has to go through a central line. Now you got central line complications to deal with as well. Infection, including endocarditis can be an infection from the central line. So when you look at the complications of TPN versus enteral feeding, the enteral feeding complications are much easier to control, especially the PEG tube. You keep her head up, she's not likely to aspirate, especially if you're checking residuals, making sure that she doesn't have too much residual. For this patient, how much residual would be too much residual? Do you remember how much she's getting? Right there. How much residual would be too much residual? This course can be terrifying to teach. When y'all know this stuff, it's exciting because then I'm like, oh my gosh, these people are going to be great nurses. And when you don't know, I think, oh, those poor patients. Terrifying. You're going in with enteral feedings in the PEG tube, you're checking residuals, I hope. How much is too much? I'm sorry? No. 100 is if it's intermittent, but these are rarely intermittent, aren't they? This one's continuous.
Does it have to do with like the time that it's going to infuse, like if it's over half the volume?
So close, man. So close. 2 hours worth. 2 hours worth is the limit. So what's the limit for this patient? 150. That was on your final exam in basic, I remember it. I can prove it. Now what's scary is how much enteral feedings have you been giving and not paying a bit of attention to that. Yeah, you always say you're not doing anything. That's because you're going into clinical, finding the patient that you can do the least amount on, sitting in the conference room, working on your paperwork. That's why you haven't seen all of this stuff. They're getting enteral feedings in ICU all the time. They're getting enteral feedings in other places as well. They got enteral feedings in the long-term care facility when you were in basic. They're very common. Okay. What's the rationale for choosing Pancreatitis over some other enteral formula? Nope, has nothing to do with aspiration. Good guess though. Remember when you were in basic and I made y'all pull those enteral feedings and compare one to the other? And we were comparing fats, carbohydrates, and proteins. And I told you, the formulas vary on fats, carbohydrates, and protein. What about the pulmonary system has anything to do with fats, carbohydrates, or proteins? The end product of carbohydrate metabolism is CO2. If your patient has a risk of retaining CO2, then Pancreatitis is a better enteral feeding because it's lower in carbohydrates. Your patient has any risk of retaining CO2, they already got too much retention of CO2, then you don't want to give them a high carbohydrate diet because then byproduct is the production of more CO2. This patient being on a ventilator is at risk of that. What other patient group might be at risk of this? Yeah, there you go. This patient has a saline law. How is she receiving hydration? Through her what? Through her feeding. putting intermittent water through that feeding. The patient's current vital signs are 110/62, 122, 14, and 102.4 degrees Fahrenheit. Her ABGs are pH 7.34, PaCO2 46, HCO 321, PaO2 90, and O2 set 92%. Which acid-base imbalance is she experiencing? Respiratory acidosis. Respiratory acidosis. What's causing her respiratory acidosis? Maybe. Could be. And if you think it's a ventilator, what would you do? To what? Increase her breath rate. Good game. That's probably not what's the problem here, though. There's something else. But that is, if that's the only thing you've got is all the normal vital signs except her pulse rate and her respiratory rate's a little on the low side, and she's in respiratory acidosis, then increasing her respiratory rate will work. But most likely that's not what's causing this one. Can you tell what might be? It's on that screen. She's got a fever. She's got a fever. Most likely. If you go back and look at that whole oxyhemoglobin dissociation curve, it will explain why that fever is causing that. The physician orders a change in the patient's antibiotic, and 48 hours later she shows enough improvement the ventilator setting is changed to SIMV. What steps will you take to prepare this patient for eventual weaning from the ventilator? So what do we need to do to get ready to wean this patient off of this ventilator? Yeah, she's not had any sedation, but if she did, you would want to extend her sedation vacations. That's exactly right. Anything else? Oops, I didn't need to do that. We're going to monitor her fluid electrolyte balance and ensure that she has adequate nutrition. Then, what are the physiological criteria for weaning from a ventilator? Maintain O2 stats. Sorry? Fighting the ventilator. Those are some good ones. You want her ABGs within acceptable limits. You want her tidal volume greater than 10 milliliters per hour. You want her vital capacity greater than 15 milliliters per kilogram. You want her FiO2 less than 50%. The maximum inspiratory pressure greater than 220. And a normal hematocrit. Those are the things that she needs to have before she's bleeding. How are we going to know tidal volume, vital capacity, and MIP? Yeah, pulmonary function test. Your pulmonary function test can tell that. The patient's family visits and her husband starts to cry. Upon seeing their father cry, all three of the children start to cry and beg for their mother to come home. What are you going to do? What are you going to do? I'm sorry? Ask them what's concerning them. Take them outside to cry. Away from the patient. What else? Why do you think they're crying? They're a little overwhelmed, aren't they? They're seeing a lot. They're scared. They're scared that this is permanent, or that she's not going to get better, or that they're just overwhelmed with it. We want to calmly point out the progress that she has made. Show them, look, she is getting better. She's now able to talk to you. She doesn't require as much mechanical support for breathing. You want to offer a realistic preview of her expected progression from this point. This is what we expect to happen. This is how long we think it'll take before we have her off of this ventilator. How much longer we think she'll be in the hospital. And then suggest that they do something together that's fun, something that's family time. Why is this important? You're not just taking care of the mom. It's not your only patient. And the mother's not going to get well if you add stress to her life. And having her family so upset is stressful. So we want to decrease her stress by helping her family do well as well. What are the physiological signs that the weaning has not been successful? You're weaning her off. What are some signs that we better put her back on? Ultrasound drops, respirations increase.
Heart rate goes up.
I'm sorry?
Heart rate goes up.
Heart rate goes up. I'm sorry, ABGs are abnormal. We got most of them. On the second attempt at weaning from the ventilator, the patient starts crying, stating she can't breathe. These are her vital signs. Her skin is warm, dry, and pink, and her heart rate is regular. What will you do? You're going to do some things to help calm her down. That's exactly right. Ask her to take slow, deep breaths. Remind her that you can reconnect at any time and supply a non-invasive delivery of oxygen. This is probably anxiety, isn't it? Not insufficient oxygenation. This patient fully recovers from her infection and is able to return home to her family. Don't you like it when they live? Yeah. These are real patients. I'm not giving you false patients. These are real patients that have these real problems, went through these real situations. All right, we're going to do some laboratory reports. We got things to get done today. Most of this stuff I went over with you before in basics, when we did vital signs and diagnostics. And then we've done a little bit of this here with some of the cases that we've done. This one, the WBC, is elevated, so we're going to look at what next? Differential. And what does this differential tell us? What? And which one is it? Bacterial. How does he know it's a bacterial infection? The granulocytes went up, the lymphocytes went down. There is an exception. And that exception is if the patient is on corticosteroids. This could happen on corticosteroids as well. So we would want to know that. However, if the patient has immature white cells, bands, and sacs, that's not corticosteroids. That's an infection. So we need to ask that question. The RBC is low, so what do we look at next? Oh, the RBC is normal. Never mind. The hemoglobin's normal. The hematocrit's normal. The MCV, the MCH, the MCHC, platelet count. So everything else is looking okay. We're just happy with that one. This patient has pancreatitis. What about this one? The WBC's okay, but the lymphocytes are down, and the monocytes are up, and the eosinophils are up. What does that indicate? Allergic response. That's probably allergies. Could just be seasonal allergies. But when those eosinophils go up, monocytes typically mean inflammation. So it's hard to use them for anything because inflammation can be from who knows what, how many sources. But when the eosinophils go up, that usually means allergic reaction. When there are only 7 out of this, I'm thinking this is seasonal. These are probably seasonal allergies. So do we need to call this one to the doctor? No. What if this was the first time this showed up on this patient? Would we need to call it to the doctor? Yes, because we can treat an infection, right? So this one we're going to treat as soon as we can possibly treat it. So we would call this one. This one's probably seasonal allergies, and we wouldn't wait for the doctor to come around, right? Go ask the patient, what do you take for your seasonal allergies? Okay, the patient's prescribed Cipro 500 milligrams POBID for 7 days. Do I need to call the doctor? Patient's prescribed, already receiving Cipro 500 milligrams POBID. I need to call the doctor, why? Resistant, I gotta get a different drug. Which one would I like? Ampicillin. Almost anything but the levo, Cipro, and norfloxacin, right? Everything else would work better. So I need to call the doctor on this. Yes, why? As long as the trough is okay, we don't need to call. They may make a change at some point, but as long as the trough is okay, we're okay. The trough's the lowest level, so if it's therapeutic at its lowest level, we're pretty happy with that. Okay, this one's got a WBC that's elevated, so we go and we look at the differential. What does that differential tell us? A bacterial infection or corticosteroid use, we gotta know which one. The WBC, the RBC is low, so when the RBC is low, we look next at H and H, and they're both low, aren't they? So a low H and H tells us what? Tells us what? Bleeding or anemia. How will we decide? We're going to look at the red blood cells indices, the MCB, the MCH, and the MCHC. This MCB is elevated and the MCH is elevated, the MCHC is okay. So what are these two trying to tell me? Macrocytic anemia. What are the macrocytic anemias? Pernicious and folic acid. Very good. Pernicious anemia and folic acid anemia. This patient likely has pernicious anemia or folic acid anemia. Now then, we're going to go to this patient's room, aren't we? We're going to look for signs of bleeding. We're going to look for signs of a macrocytic anemia. If they have folic acid anemia, we expect that they also have a medical condition called what? What's the most common cause of folic acid anemia? I'm sorry? Alcoholism, because it causes malnutrition. Malnutrition is the #1 cause of folic acid anemia, but in adult patients, a lot of times, especially in the United States, a lot of times that's due to alcoholism. So we're going to get an alcohol intake history. Pernicious anemia is most likely caused by what? Lack of intrinsic factors, so it's going to be something GI. What patients are likely to have a decreased intrinsic factor? I'm sorry? Patients with history of ulcers, a good one. Who else? Who else? Crohn's, but usually stomach. Intrinsic factor is from your parietal cells in your stomach. GERD might. Weight loss surgery patients, definitely. Anything that's happened to the stomach. Diabetics are because they experience peripheral neuropathies, and one of the peripheral neuropathies they experience is gastroparesis, which is paralyzing of the stomach. That's one of the ones that they experience. So we're gonna look for those things. If the patient has folic acid anemia, what's that gonna look like when we go look at that patient? What signs and symptoms are we gonna see? I'm sorry? Fatigue? Anything else? Mouth sores? Pale, hot pallor? Although not usually, because remember this is a large red blood cell, so pallor's not going to be as prominent as it would be if it was a small red blood cell, pale red blood cell like in iron deficiency, which is much more pallor. You're going to see signs of malnutrition. What's it going to look like if it's pernicious anemia? I'm sorry?
Full body.
Yeah, but now we got to differentiate between the two. Nerve damage. You're going to see neurological changes. In particular, what you'll see early on, if it's an early sign, they may have a little bit of mild memory loss. And when I say that, I mean things like they're struggling for dates, to remember a date, or perhaps one of my friends that had this, she would forget to take her vitamin B12 shot, and she'd come in and she couldn't make any decisions. And when she couldn't make any decisions, I'd say, "What was the last time you took B12?" And she'd look on her calendar, and every single time it'd been over a month. So little things like that, numbness and tingling, they'll complain more of that, more neuropathy types of things. When they have that day diabetes that progresses, they're going to have more problems with nerves overall. They're going to have the beefy red tongue. But early on, it's more neurological, memory, forgetfulness, things like can't make a decision, numbness and tingling, very mild symptoms that you'll see with that. So we can differentiate whether we've got bleeding and macrocytic anemia in those situations. Okay? Next one. This one's got a normal sodium, a low potassium. Are we calling that? Yes, we're calling that one. Chloride of 91 is low and a CO2 of 39 is high. Are we calling that? No, we are not. When was the last time you saw anybody call a doctor and say, "Let me tell you what the chloride and CO2 is"? No. What does this indicate? When that CO2 goes up, that indicates what? CO2, when it's a serum, is an indicator of what substance? Sorry? I told y'all the basic. Maybe go through chapter 1 of it. How many of these labs have you looked up on your paperwork? Did y'all not have any patients that had CO2 levels on them? It's bicarb. When it's serum, it's an indicator of bicarb. So the higher that goes up, the more bicarb there is in those that blood. So it's an indicator of alkalosis, isn't it? Metabolic alkalosis. This patient has metabolic alkalosis. If this goes up, that one's going to go down and vice versa. Random glucose, what are we going to do with that? We calling it? Are we calling that? No, it's random. We got to have more information. We got to look at the BUN, we got to look at the creatinine. Are we calling this? No, why? The creatinine is normal, so what is this? Dehydration. We're not calling that. That's normal. The albumin's a little low, isn't it? You got to worry about what when the albumin's low? Third spacing. The bilirubin's high, the alkaline phosphatase is high, the AST is high, the ALT is fine, and the calcium is fine. So what did I tell you the other day about this one being elevated and this one being normal? Above the liver. I would be a bit surprised if this is my pancreatitis patient. Okay, sodium's fine, potassium's fine, chloride's low, CO2 is high, we got metabolic alkalosis. BUN's fine, the creatinine's fine, the glucose is fine, and the calcium fine. Nothing there to call, is it? That's pretty darn good. This patient was NPO for 3 days. Scheduled for Depakote 250 milligrams POBID with the next dose at 900 and has been taking it regularly for the last 2 days while in the hospital. Do we call it? No, what are we going to do? Give her the dose. That's exactly right. We're almost there. The sodium's low. Do we call that sodium? Nah, we're waiting. When would we call that sodium? How low does it have to get? Like around 120 is exactly right. And then what signs and symptoms will we see of it? Neuro. Potassium's okay. The chloride's low. The CO2 is normal. BUN is fine. The creatinine's fine. Glucose is a little low. Are we calling that glucose? What are we doing? What are we treating it with? Orange juice, yeah. We're giving you 15 grams of fast-acting carbs, aren't we? The calcium's fine. SAD rates, 98. We calling it? What does it indicate? Inflammation of some sort. We don't call that. Here's our ABGs. Our PCO2 is 21. Well, that's low, isn't it? Look at O2 at 173. So our PCO2 is very low. Our pH is 7.459. So this patient's in what state? Alkalotic, and if this is 21, what state are they in? Respiratory alkalosis. What happens? What causes respiratory alkalosis? They're hyperventilating, right? They're hyperventilating. So what do we need to do in this case? Look at the respiratory rate. But they're hyperventilating, are they not? That's what causes respiratory alkalosis. They're blowing off too much CO2. They're blowing off too much CO2. So what are we going to do? Cut back on some of that oxygen, right? We're going to cut back on some of that oxygen. What are we going to do that respiratory rate? Anything? We're going to cut back on the oxygen. Also, as I see this PEEP on here, do y'all know what the problems with PEEP are? If it's putting a little pressure on those alveoli each time, what kind of problems can it cause? I'm sorry? It can cause the lungs to collapse. What else? It increased that volume in the interthoracic area, so you can see hypertension with that. That's something else that it can cause. Just think about that. All right, the patient receiving heparin 1,200 units per hour since yesterday. Are we calling this? Yay or nay? No, why not? Yeah, how far above normal? 1.5 times, 2.5 times what?
Control.
The control. So create a new range. What is 1.5 times 27.9 and 2.5 times 27.9? 49.85 to 69.75. So this is falling right in there, isn't it? So we're happy with that. Receiving Coumadin 5 milligrams POQHS. Treatment of atrial fibrillation. Are we calling this? Yes, why? What if it's 9 o'clock in the morning? Are we calling it? No, just when they give it this Coumadin. At 9 o'clock to 9. So if the doc has enough time to get there before we need to give it, then we don't need to call. But yes, this needs to be notified, doesn't it? It needs to be between 2 and 3 if we're treating April 5th. Again, more liver stuff. Now we got everything elevated, don't we? Well, we don't have the direct bilirubin elevated, or the total bilirubin. The alkaline phosphatase is low, and the AST is high, and the ALT is high. What do we think's going on there? What causes the bilirubin to go up? Breakdown of red blood cells. The breakdown of red blood cells is what causes the bilirubin to go up. So what do you think caused this? Huh? Nah, cirrhosis. When cirrhosis happens, then you start seeing the breakdown of red blood cells and you get the elevated bilirubin. I'm thinking, okay, what's this guy taking as a statin? We'll see what that statin drug looks like. I bet he's got this one's on statin or something else. Maybe it's an acetaminophen overdose. We calling that one? Yeah. Why? What is it? Yeah. And if it's not hurting, we're not calling. If it's hurting, we're calling for pain medicine, but not because of the finding. There's nothing they're going to really do about that finding. Sodium's okay. Potassium's very low. What would we expect to be the signs and symptoms of that? I'm sorry? What's going to be the signs and symptoms of hypokalemia? Cardiac what? Dysrhythmias and what else? Muscle weakness. Yeah, real floppy muscles. Hyperkalemia causes excited muscles. That creatinine, look at that creatinine. I'm surprised that BUN's so low. Look at that creatinine. If this is the first time this has happened on this patient, are we calling that? Yeah, we've got renal insufficiency. We've got renal insufficiency going on. Well, there's the WBC count. We go down, we look, and we see that the monocytes are high, aren't they? Doesn't look to be that this patient's having an infection. It just looks like they're having some form of inflammation. I'll be looking to see if this is like a rheumatoid arthritis or something. Look at their hemoglobin hematocrit. Wow, that's high, isn't it? I don't like that. I'm sorry? When they're hemoglobin, yeah, I'd like to see their center. When their hemoglobin hematocrit are that high, what does that tell us? Why is that a problem? You got too many red blood cells. You're pumping on too many red blood cells. Increase the risk of clotting. Could be, it's not because not high enough, but it could be something like polycythemia vera, where you make too much blood, causes clotting problems. Your blood gets too thick, it clots too much, they have to drain it off. And that's fine. That's fine. All of these are fine. What if those platelets were too low? What would that indicate? If your platelets were 140, what would that indicate? Bleeding, exactly. Coumadin, are we happy with this? Yes. Right where we want it to be. Any questions about the lab reports? All right, I've got another little treat for you. I know y'all like treats before we do the dosage count. If you have your unit 3, and your unit 4 objectives, you might want to pull those up. Questions, I got questions, I got questions. So here's a question for you that addresses the Unit 3, Number 1 objective. Anybody gonna answer, or you'll find the answer? Is it not wanting to? No, it says it's done, I mean, it says it's, you can, yeah, here it goes, people are doing that. There's more than AW in here, somebody answer these questions. Make it worth my while to have put these in here. I've got a question for each one of those objectives. If you answer them, you'll get a preview. If you're not gonna answer them, we can just take the dosage calc and go home.
I just sign on this.
All right, I'll take 50. Uh-oh, what did I do? Did something I didn't intend to, right there. Okay, most of you knew. So this question was really asking you which one of these 4 strips is atrial fibrillation, wasn't it? And the characteristics of atrial fibrillation are that there are not identified P waves, because it's just a bunch of flutter there. And usually the rate is very, very irregular, which this one was. Okay, that's cool. So the first objective was about recognizing diagnostic or analyzing diagnostic, something in that. Is that what that one's about? And this one then is the significance of it. Would that be correct? There we go. We just went through that. The ESR is an indication of inflammation, isn't it? Okay. What's the next objective? I'm sorry. recommended treatments. Let's see if that's what this next question is then. Y'all don't like this question. Taking you a long time to answer it. So you don't like this question. And the reason you don't like this question is because we didn't have a case of pancreatitis, did we? We have a case of pancreatitis. And you saw the very first sentence, this nurse is caring for a client suspected of experiencing pancreatitis, and you freaked out. That's what y'all do in the test. Then it says the lipase level is 153. We did talk about lipase levels last time we were together. Remember, amylase and lipase. Lipase indicates that the patient has pancreatitis, and then amylase indicates that the patient has gallbladder problems. However, if this patient does have pancreatitis, what do we know about pancreatitis based on our cholecystectomy case, or cholecystitis case that we had last time? We know it hurts, doesn't it? Don't we? We know it hurts. They're in the same area. They cause the same sorts of things. Remember, I told you, if you've got one of them inflamed, the other one will be inflamed sooner or later. They're too close together not to. But the main thing you should know about that is that it hurts incredibly. Matter of fact, I probably even mentioned that about pancreatitis. So the correct answer is, it hurts incredibly, so let's give them a low-fat, high-protein diet. What the factor we do know that transfers from that is that it's incredibly painful, so the correct answer is low-fat, high-protein diet. Is that the correct answer? No, what's the correct answer? Fentanyl. Fentanyl, but we didn't talk about fentanyl. We didn't talk about low-fat, high-protein either. The only time we've ever talked about a low-fat diet, we talked about cardiac, and it wasn't high protein, was it? What was it? Moderate protein. Moderate protein. Because in this case, if you go with low-fat, high protein, you're decreasing the energy for that patient. Is that really what you wanted to do? No, because you're also having to decrease the carbs. You're decreasing the carbs, you're decreasing the fats in order to go high protein. Remember that wheel I threw out for you that y'all were so proud of? Yes. This was a bad answer. 65% you gave me a bad answer. But you knew pain, and that's what I'm seeing from you guys. Even when I'm working in small groups with you, that's what I'm seeing. I know the content is this. However, if you give me a question, I'm going to choose this over here. I'm not going to match my content to my application. Why didn't you like this one? You've seen it a gazillion times in the hospital, haven't you? If they have a PCA, isn't that what they're putting in their fentanyl? And aren't they getting a punch every 10 minutes? And isn't the concentration 10 micrograms per milliliter? Yeah, you've seen it a gazillion times. So why didn't you choose that? You knew that there was a lot of pain, and you knew that fentanyl was the drug that you see in the PCA pump. So why didn't you choose it? The answer to that question might get you a better grade on this exam. You've got to take the content that you know is right and apply it to the right situation. What's wrong with A? I did just address this the last time we were together. What's wrong with A? They're gonna be MPO, so they need D5 or D5NS, something with dextrose, D5LR. They need something with dextrose in it. Remember me talking about that? You're gonna make this patient MPO, and when that happens, we need to get some dextrose in there. This is hypotonic solution. So if it's hypotonic, what's it gonna do? It's gonna go into the cells, isn't it? We need something with a little dextrose too for energy. What's wrong with D? Yeah, that's why you chose it, it's anti-nausea, but it has another effect. What is it? That's one of its effects, anti-nausea. But it's anti-nausea because of its primary effect, which is what? Increased gastric emptying. So you want the stomach to be hyperactive? No, that's what you just wrote. You just chose to make that patient's stomach hyperactive. Well, let's do the next one. So what's the next outcome that we're looking at? Oh, call immediately. Which one's to report? That's what this one is. I like this one. Go fast. Oh, slow down. So close. Some of you really like it. That one. Okay, so when we're looking at this one, it's asking us if we had these 4 results, which one would be the one we want to call immediately to the provider? 50% of you knew the right answer. They were going to report the sodium potassium. Why? Talk to me. Potassium's high? Some labs, that's perfectly normal. 3.5 to 5.3, the ones that we were just looking at, that was normal, wasn't it? No, so if you don't know, because each lab can be a little bit different, this one is obviously way out of range. And if the WBC that's elevated, it indicates what? Infection. This tells me it's bacterial, isn't it? So I've got to give an antibiotic. Hemoglobin hematocrit are low, but we're not going to treat it. When do we treat a hemoglobin? Less than 8. Most of the time it's even below 7 these days. And or I should say, we see active bleeding. So if it's less than 8 or we see active bleeding, which we don't have that in this scenario. I'm guessing that the next objective has something to do with changes in condition. Is that right? Is it change the care plan based on changes in condition? Is that one? It'll be really interesting to see what you put. Okay. What makes this one so hard? You're gonna do every single one of these, aren't you? So now you gotta say which one you're gonna do first, don't you? Because we're gonna do every single one of them. What's the problem? What's the change in condition? The patient is developing what? Fluid overload. The patient is developing fluid overload. So the priority is to stop giving them fluids and get rid of the fluid overload, right? So the priority is going to be D. You got to stop those fluids first, because that's your problem. Your problem is you're giving them too much fluids. So we're going to stop those fluids. But we want the IV access site, don't we? Because what drug are we about to give? Lasix, yeah. So we're going to want the IV access device in place. We're going to stop the infusion. Then what are we going to do? Position them, and then what are we going to do? Administer an oxygen and then call the provider for the Lasix, right? Exactly. So these aren't so hard, are they? There's only been one that was really hard. Y'all make them hard. I hated giving this question up to you, because this is a big question I would love to have put on the exam. I can still put it on the exam? Y'all are sweet that way. All right. So what's going on here? What's going on with this patient? We don't know what's causing the abdominal problem, do we? They were admitted with unknown etiology, has the pain, and now we go do an assessment, and if the abdomen is distended, the abdomen has hypoactive or absent bowel sounds, not even hypoactive, there are no bowel sounds. Those kind of fit together with something, don't they? And then the patient has a hoarse voice quality. What in that scenario tells you what's going on with that hoarseness? What's caused that hoarseness? Huh? Distension's doing what? Pushing up on that diaphragm, isn't it? It's pushing up on that diaphragm. So the distension is bad enough that it's pushing up on that diaphragm, and now that's affecting the patient's ability to make words. What would cause such a bad distension in hypoactive bowel sounds? What should cause that? You have no idea what should cause? Huh? An ileus? You were thinking what? Like a hiatal hernia? The hernia itself causes it? The hiatal hernia itself, all patients who have hiatal hernias have really distended bellies with no bowel sounds and a hoarse voice. A rupture, thank you. This is caused by a rupture. That's what all these signs and symptoms say. You have bleeding into that abdomen. Now, if you got that part, what's the correct answer? Notify the provider. This was the correct answer. You wanted to do this because of that hoarseness, didn't you? Or because you're thinking, well, I haven't done a respiratory assessment. I haven't done one. And I'm going to assess everything first. You got signs of bleeding in that abdomen, it don't matter about those respiratory sounds, because They're not gonna get any better, they're just gonna get worse until you take care of that bleeding. Because now the patients have decreased oxygenation, they're going to have more pressure on that abdomen, which means the lungs are not gonna expand as well. So the assessing the breath sounds no longer a priority, this becomes the priority. You have the signs and symptoms of bleeding. I find semester after semester that somewhere in your education, y'all miss out on understanding that when there is GI bleeding, it causes distension, absent bowel sounds, and hoarseness. It also causes referred pain. Where's the pain referred? Bleeding, not pancreatitis, not cholecystitis, bleeding into the abdomen causes pain to refer where? Right shoulder. Now, that, where y'all missed that? But y'all missed it, and you're not the only group that did. Y'all missed it. When there is abdominal bleeding, you will see distension getting worse and worse to the point that the voice gets hoarse. You'll see referred right shoulder pain. You will see the absence of bowel sounds where they'll start to really get hypoactive and eventually stop. As soon as I see abdominal pain of unknown etiology, that means you're having trouble diagnosing what's causing that. It could be an ulcer, and that ulcer could be ruptured, it could be perforated. Make that number show. I think that number is 112. Oh, there it goes. Yeah, 112. Let's see what we got. The surgeon is correct. If we think that this is related to the surgery, and we do, because we think this is what? 12 hours out, however many hours at 12? Yeah, 12 hours after surgery, we have too low a urine output. We think that's caused by? Caused by what? What's it causing? Either the kidneys are not getting perfused, so we have renal insufficiency, or the bladder is full, we can't get it out. So we have urinary retention. Post-operative urinary retention or renal insufficiency. So if it's a post-op, if it's a surgical complication, we call the surgeon. That was the last one, wasn't it? That number 8? We have one more. Let's see what that is. This one must be the evidence-based stuff. I gave y'all the evidence for in my care. Did you notice I didn't ask about starting doing the EKG first? Yeah, because so many of you come up to me and say, now which one of those do we do first? So I already know you know it. So while I ask the question, then I already know you know it. Let's see if you know this one. We're going to give the oxygen first. Good. Remember, it it's oxygen, nitroglycerin, aspirin, morphine, and water. That's right. Okay, so what has this shown you about preparing for this exam? Have we been doing these things? Have we been doing these 8 objectives in here over and over and over? We definitely have. We definitely have. And now remember, it's cumulative, so the first 8 objectives will be on it as well. Cumulative, but I've just shown you questions that could be easily asked on the 8 objectives that I had, that are new for this exam. You'll need to not focus on so much on disorders and focus more on the decisions. Focus more on the decisions. That's what this class is about. All right, let's do dosage count.